Hey, good morning, everyone, and welcome to Euronurse. I'm your host, Vic Sinise. Welcome to the show. If you're watching us live, great. Glad to have you on board. Be sure to hit the subscribe and the like button. For some reason, it does something. And if you're not getting our email, be sure to go to our website and register for our MailChimp email to get that every week. And our Euronurse.com website is the best place to go to learn more about the show. Very best place to go. We have all of our past episodes available, 96 of them now. Woo-hoo. Want to listen in your car? No problem. Go to our Euronurse Plus area. Our audio podcast comes out every week after the show, so you can listen to it in your car. And hey, put this on your save the date, June 29th. June 29th will be our 100th episode. We're going to have a whole bunch of stuff going on. I'm going to have some gift cards giving away, $10, coffee with us. I've got the experts who are going to be joining us as usual. And some of our sponsors that have helped provide sponsorship for the show are going to join us and talk about the show. And even you can be a part of the show. If you want to send a quick video to me, I'll have information on the website how you can just take a little quick video of why you like the show and who you are, and we'll add that all together. So it's going to be a fun show. Now, this week, I'm really happy to have Landon Trost joining us. Dr. Trost is going to be talking about vasectomy reversal, reclaiming fertility. So let's go ahead and meet our experts right now. Experts, welcome to the show. Hey, everybody. How's everyone doing today?
Hi, good morning.
Nice summer. Another nice summer day in June. At least the cicadas are getting a little quieter out by me. I don't know about how you guys are doing, but they're crazy. So I am the host of the show, Vic Sinise. I've been involved in urology for the past 40 years, and this is my way of giving it back, and I'm glad to do it. Always great to have new topics to talk about, and looking forward to today's discussion. So feel free to put any comments in the comment box, and we'll bring up your questions. Lori, go ahead and introduce yourself.
Good morning. My name is Lori Atkinson. I'm a certified urology registered nurse. I've been working in urology for 26 years now. I'm happy to be here. I work for a large urology practice in Geneva and Winfield, Illinois.
All right. Okay, and Landon, go ahead and take it away with your introduction, and then we'll bring your slides in.
Okay. Yeah, no, I'm Landon Trost. I'm a urologist. Background, I have one slide that goes into a little bit of background, but after residency, I did 3 fellowships in andrology, which is basically a subspecialty looking at men's sexual health and infertility. And then I was at Mayo Clinic as the chief of andrology there for about 7 years and loved it. Would have stayed there forever, but my wife said, "You're too busy. You got to change jobs." And so I, left Mayo about 5 years ago and started up my own practice in Utah. So we're in Orem, Utah now.
Cool. How's your weather out there?
It's great today. Yeah, we have a real good, last week and this coming week looks to be really nice. So yeah, it's a good time of year.
All right. Let's go ahead and add you into the stage. So if you just switch your slides over, you'll be all set.
Okay.
Perfect.
Well, no, I'm grateful for the chance to be able to present, and thank you very much for the introduction, and grateful to be with you. I think it's a wonderful program, and it's a great group, and always happy to present. The topic today is going to be a little bit different, though. So this one is vasectomy reversal, reclaiming fertility. This is kind of a niche topic in general. It's not one that 90% of Americans are going to run across or anything like that, but instead it tends to be a little bit more nuanced. And then I'm just going to do a couple of comments, maybe just 3 slides on general male infertility, just a couple kind of interesting facts there, things that people should know, that type of thing. So again, appreciate the time. There aren't any relevant disclosures for this particular topic. As far as kind of a relevant background, so I mentioned I did a fellowship in andrology, which is basically the study of men, I guess, if you were to break it down. And the reason for this topic is in our center, surprisingly, we do the highest volume of vasectomy reversals in the United States and possibly the world. We do more than 1,000 per year. And just to put that into context, the largest publication ever published was a little over 4,000 patients, and that was over 40 years. And so typically, centers will do, between 4 and maybe 50 a year of reversals, if that. And so we do a very, very large number of them. And so it's just somehow it's become our sub niche, that and Peyronie's disease. I just wanted to start off with a couple basic statistics on reversals in general. So when you look at vasectomies, they're very common. So in the United States alone, there's estimated to be over 500,000. Some put at 580,000, some even more per year. So, relatively very large number of vasectomies performed. And interestingly, about 20% of men regret it at some point. And you look at how many consider a reversal, it ends up being around that same number, anywhere between 18 and 25% or so. If you look at why, so why do people regret a vasectomy? And it typically is if they're in an unstable relationship, meaning kind of an on again, off again, or just no relationship. If they're under 30 years old at the time of the vasectomy, if they've never had kids or only have very young kids, if they're doing the vasectomy because of complications of pregnancy, so, some issue where they say, oh, you shouldn't get pregnant again, something like that. Or if they were going through a financial crisis at the time of the vasectomy and life was just hectic and crazy and they got the vasectomy, all of those are leading predictors of someone who's going to potentially regret it. Now, despite that, even though 20% of men consider a reversal, only 2 to 5% will ever actually seek a reversal. And so that ends up equating to roughly 20,000 reversals are done per year. And when you look at why so many people consider it, but then only a small percentage do it, a lot of times it's because they'll go see their physician. Their physician says, oh, you can't do a reversal, it's permanent, or the success rates are too low, or you just don't even know that it can be reversed at all. So there's a big discrepancy between the potential versus how many are actually seeking them out. Well, I wanted to give some background here because it's important to know the difference between IVF or in vitro fertilization and a vasectomy reversal. So post-vasectomy, you really only have 2 options that you can reasonably consider to try to get pregnant. One of them is a reversal, and that's just an illustration that we had commissioned when I was during my time at Mayo. And then on the right is a dish where they're getting ready to do, in this case, probably ICSI, but you're doing in vitro fertilization there. So those are your only 2 options. And I think some people don't realize that some will say, well, I want to do something like intrauterine insemination, which is a much less expensive option, but it's just not possible post-vasectomy. You really have to do one of these 2 or both of them combined. So when you look at in vitro fertilization, I pulled some of these slides just from Wikipedia because I don't do in vitro fertilization for it, but it's a several step process. The first part on the female side is, and here they show a needle going into the uterus. It's not done quite like that, but they do get drugs that will hyperstimulate ovarian production. So this ends up being one of the most costly parts of in vitro fertilization are the medications. And there are different tricks. Sometimes you can get them from other countries or things like that, but they tend to be expensive. You're looking anywhere between 5,000 and 12,000 or so, sometimes just for the medications. Once the eggs are stimulated, so you get more eggs being produced, they then do a transvaginal retrieval. So usually they'll have an ultrasound guided aspiration of the eggs. Once you've retrieved the eggs, you then fertilize it. And this is where, in vitro just means like in a dish or, ex vivo outside the body, that type of thing, where they'll fertilize it. And then they let it grow up. So, and there's different machines for this. There's certain things that will take a picture periodically that will show kind of a time lapse type growth. But you let them grow usually until they become a 5-day blastocyst. At that point, you then look at which ones are best, and you can transfer one or more. Most centers will do just one, but typically one or more into the uterus. And then you wait and see if it leads to a pregnancy, and then you follow from there. The remainder of the embryos you usually freeze at that stage so that you can potentially put them in later as a frozen transfer. So that's, you can see it's kind of an involved process there. And as it shows in the bottom left corner there, it usually takes about 3 to 6 weeks or so for it to go through. Well, that's good on the female side, but on the male side, you still have to get sperm out somehow because it's blocked because of the vasectomy. And that's where you get all these, 4-letter, acronyms for it. So you've got PESA, which is a percutaneous epididymal sperm aspiration. And you can see in the picture on the left there, you basically just, grab the scrotum, you take a needle, usually you'll use one a little bit bigger than this one, but you take a needle, you puncture the epididymis a couple times, and it's all based off of feel typically, and then you just suction out everything you get. And that usually includes tissue, tubules, blood, sperm, everything. You have TESA, which is this testicular sperm extraction, and that can either be done through a biopsy gun that they're showing here, where same concept, you basically just put it into the testicle as opposed to the epididymis. And this gives you seminiferous tubules with sperm as well. Now, both of these techniques are ones that aren't terribly difficult to do, and you can do them with just local numbing medicine, but they generally don't work very well. You get relatively small numbers, you get a lot of blood contamination, and the complication rates with these, believe it or not, are actually higher than some of the other ones I'll show in a second. And it's just because you're kind of blindly passing needles, it bleeds into the sac, and if they have a redundant sac, it can fill up with blood, and you can have issues like that. So those are two. The ones that are probably more gold standard, I think you'd say, would be this MESA and oh, sorry, I put TESA there, but it should be TESI. MESA is the on this picture on the right, this one right here, which is basically you access the epididymis, and then under a microscope you'll do a little micro dissection where you find the best tubes, pop them, and then you take sperm directly. You usually get much bigger numbers that way. You have less blood contamination, and it also doesn't damage your future if you do decide to do a vasectomy reversal later. In fact, I just did a reversal yesterday on someone who had a MESA done and had completely normal sperm counts in his vas deferens, even though previously we'd done the MESA. A TESI, this is a testicular sperm extraction. So the other one, TESA, is testicular sperm aspiration. That was the one I showed on the other slide. But TESI, you basically go in and you take a bigger chunk of tissue, ends up being maybe 2% of the testicle or something like that. And then that gives you really big numbers. You can save multiple vials and it lasts a long time. Well, when you talk about IVF is a big, an overarching name. So that just basically includes anything where you're taking sperm, eggs, mixing them outside the body and then putting it back in. On the left is kind of the traditional IVF process where you've got the eggs, you put a whole bunch of sperm in there, and then you just wait to see which one fertilizes. Once they start fertilizing, then you do the other process where you grow them up for a little bit and then place them inside the uterus. On the right, this is a relatively newer technique compared to IVF, which is intracytoplasmic sperm injection, or ICSI. And that's where they can take one sperm. You can't really see it real well here. This is a Wikipedia picture, but likely that may be the sperm right in here. You insert this tiny, tiny, tiny needle into the egg. And here the egg is being held on by this little suction tip here. And then you deposit the sperm in the middle of it. And then you basically pull the needle back out. This is a real neat technique since it allows for very tiny numbers of sperm to be used. So this, more and more people are starting to do ICSI almost preferentially over IVF. This just gives you an idea of what it looks like over time. So, this is the stages, and you can get to a 5-day blastocyst here. This is typically the stage where they'll go ahead and get ready to implant. And so ideally you want them to grow up to this stage. So they freeze better, they do better at this stage compared to other stages. All right, so that's IVF as far as background. Now I'm just going to show kind of the steps of this vasectomy reversal. I think I have a bunch of surgical videos, but I found animations are a little bit easier just to show the anatomy and things. So I'll just kind of play through that a little bit here. So this is showing, so you got testicle, epididymis, and then the vas deferens. Here you can see it's kind of coiled. This is called the convoluted vas, and then it becomes more of just a consistent vas. I'm just putting this here as a sign of where the vasectomy was previously. Sometimes you'll get a lump in there. We call it a granuloma, which is just sperm that had leaked out and causes a lump. Usually that'll cause testicular pain for a while after as well. So this is going to be the site of the vasectomy, on the video. So to do the reversal, basically first step is you need to access the area. So we do a transverse incision. There's different approaches. There's not one that's the best thing. You bring up the vas where they did the vasectomy before, so you don't necessarily make a huge incision, bring out the testicles, anything like that. And then the video is going to show that you're going to cut across the area, and you're going to sample fluid from this side. This is the side going down to the testicle, and this is the side going up and out of the body. So you're going to sample the fluid from this side, and then you wait to see what it shows. And this is going to be a big determining point as to what you do. Now, if it shows, like in this case, and this is just animated sperm, they don't really, you can only go back and forth so many times with animators before, you feel too guilty, but they don't look exactly like this. But so if you see sperm, then that says, all right, I can just attach those tubes back together in what's called a vasovasostomy. Now, if you don't see sperm, like in the other one, on this side, then that means you have to do an epididymovasostomy where you're going to attach it to the epididymis directly. So in this case, the one that didn't have sperm, you're going to have to deliver the testicle. In the case where it did have sperm, you're going to be able to just attach these tubes directly. And so that's showing kind of the two areas. So, oh, sorry, that's the downside to, thinking I could control this as we go. So it's showing you make an incision into the epididymal sheath here, you find an epididymal tubule, and then you're just going to attach the two directly. Now these are tiny, tiny, tiny repairs. Because they're so small, they tend to fail more often than these repairs. But if you need to do an epididymal vasostomy and you don't do it, you just do a vasovasostomy, then it just won't work, or it's very, very low success rate. So you do need to be able to do these kind of attachments when you do the procedure. So here it just shows you're going to check, and then here you'll same thing. You'll sample that, make sure there's sperm, make sure you're attaching to the correct tube, and then you'll just finish up your repair, which is just going to be 2 layers of sutures and then supporting sutures and things like that. Put everything back in, and then the procedure is done. Close it back up. So if you put them on a almost like a table, kind of a comparison here, looking at advantages of IVF versus reversal, there's no right answer. And if anyone says, oh, you need to do X or Y, in the far, far majority of cases, that's not true. Now, sometimes you really only have one option, but in most cases, both are an option, or both. Some people will just do both at the same time. So in vitro, on average, it's faster per attempt, because if it works, you could be pregnant within 2 months without too much of a problem if it's successful. You can also get pregnant on a schedule. We'll occasionally get someone who has, they may be an actor or something like that, where I can't get pregnant on these months, but I can get pregnant on these ones. In those cases, in vitro tends to be a little bit better there, because you can predict it. You can start your cycle on this day. You can say, all right, it's either going to work or it's not, but we know you're either going to be pregnant or not on this timeline. Sometimes you don't want much of a role on the male side. So the male side says, no way am I going to have any sort of procedure. Now, granted, you have to have something because you have to get sperm out, but you may not have to have a reversal, for example. And sometimes they don't want to have a reversal. Sometimes you want the vasectomy still to be intact. And so IVF gives you that option where you can just retrieve sperm, but the vasectomy is still intact. On rare occasions, I would say in vitro is required, and there's no other options because of specific female factors. And that may be cases like where you have tubal obstruction or things like that. But in general, most cases, it's not absolutely required. So things like endometriosis, PCOS, things like that, which are much more common, you can generally do either approach. One advantage of an IVF is you can do pre-implantation genetic testing. So especially if like the female partner is older, so say 43, 44, 45, and you have a higher risk of trisomies or other chromosomal abnormalities, or if one or both of you has some genetic condition where you want to see does the baby have that genetic condition, you can do that with IVF, whereas you can't with a reversal. Costs overall on the IVF side, it costs about $15,000 to $20,000 for the first cycle, and then usually about $5,000 to $8,000 for each additional cycle if you have frozen 5-day blastocysts or frozen embryos, because those are going to be less expensive to get everything ready and then to do a frozen transfer. Plus, you have the cost of the male side. You still have to get sperm out, and that'll vary anywhere between $1,000 all the way up to $12,000. On the reversal side, so in general, it's less invasive or risky on the female side. You're not needing to hyperstimulate the ovaries. You don't get any of those potential risks of the hyperstimulation type syndromes. It almost always is more cost effective. You can see some centers that'll charge up to $30,000 plus for it, but usually if you look around, you can get it between $2,000 to $12,000. In our practice, we do all the fertility things as a charity, so we don't make any profit off of. And I mean, it's not a formal charity, but everything is set at cost, and so we tend to be on the low end of everything. But they tend to be in this $2,000 to $12,000 range. You also have the ability to have children naturally, so you're getting pregnant on your own, natural ways. Some people prefer that versus others. You can also have multiple children if it's successful with a single procedure. So you can go on to have several kids in many cases for it. And then overall, and this may be a debatable topic depending on the specific center that you're comparing. But in general, if you go to a high volume center, a place that does a lot of these, your success rates are going to be higher per attempt in all settings, including advanced maternal age, except in those cases where you have to do IVF. And that's just, I think, because you can try multiple months. Whereas, once you've done one procedure, you can try for 2-3 years. Whereas with IVF, it's a single shot type outcome there. All right, so how do you find success rates? So SART is wonderful. You can go to sart.org, so SART.org, and on here you can look at IVF success rates. And if you click that, you can put in your zip code, and it will show you IVF centers near you, and they have to report their success rates. So it's a wonderful, wonderful requirement because it allows you to compare, one center to another. It also shows you how many cycles that center is actually doing, because people can advertise any way they want, but you want to see the true numbers of how many they're actually doing. Now, when you go there, this is just, I picked a random zip code and pulled this up just to show you, but so this shows you roughly what their success rates were back on the years that it's checking. And so here you can see for a female under 35 versus 35 to 37, all the way up to greater than 42, the live births per intended egg retrieval. So in other words, you're going to start an IVF cycle, all transfers. So I do one retrieval, but I may put a lot of transfers in type thing. If you look at just the first embryo transfer, singleton births, meaning that you don't have twins, triplets, things like that. If you're under 35, your success rate in this particular center may be 35%. If you're over 42, it drops down to 3%. So you can see there's a pretty rapid decline between 35 and 42 on the maternal side. And so anyways, this site is nice because it just gives you a chance to do that kind of direct comparison, so you can see outcomes there. Now on the reversal side, I'm going to highlight a couple things here. So this was it. So when you look online success rates, you'll get people that'll say, oh, X% success, but you have to look at what they're using to define that. So most often people will use this very lenient definition, which is either sperm at any point, or even potentially saying, all right, I'm only going to pick vasovasostomies. I'm only going to pick people who are less than 9 years out, or whatever the case. And you can see success rates, and this is very early. These are like our very first cases we did. We're getting 92% success rates there, but if you get more strict, so if you say more than 15 million at most recent follow-up, now it drops to like 50% or so. Now around this time, we invented a new technique called the revas, and I'll show some slides on that in a second. And you can see, depending on the technique you do, you can actually boost those success rates quite a bit, but it just shows you that the definition you per year versus a center is doing many, 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 there's going to be a very big difference in outcomes. And then there's a technique difference depending on which technique you use for the reversal. Well, revas, this was just something we did. So I found when we would get failures, either ours or other places failures, a lot of times they had ripped apart. And so we developed a technique where you basically put the vas together and then you give some extra reinforcing sutures. So just an animation showing, vas being put together, inner sutures are placed, the outer sutures are placed, and then it's there, and you have sperm going across is the general idea. Well, if it gets under strain, so you pull on it, just normal wear and tear post-op, you can get either some of the sutures pulling or some of the blood supply, and then you get a stenosis or a stricture that happens. And that can happen even, extra strengthening sutures in there to make it so that if this gets pulled, it's going to pull on those sutures first before it ever threatens your repair. And so it's just going to give you a lot more strength. Even if a couple tear, you're going to have plenty of strength where it's a non-issue. Now, since we published this, we've revised this so it doesn't form this big loop anymore. Instead, we have it where it's a longitudinal type thing, so it feels just like a normal repair, but then you get all the strength of the revas type sutures. So, and again, that particular technique significantly improved outcomes, and I'll show those here in just a second. Well, kind of getting back to that concept of definitions, when you look at now, so what are our data now, now that we're several thousand cases in, and this is for our center because we all do, the same technique, but now our overall year, we had one who didn't have patency, so 13 out of 14 in this case, but all these. And so you do get better. Like the more you do, you just get better outcomes. And then you can see the sperm counts are staying relatively stable over time in these groups. Now, this study we did similar to ibuprofen in many ways. And we were looking at different doses of it to see if it could impact or improve outcomes. And you can see if men did a high dose, now this was just 20 milligrams, so I mean it's high but not that high, their pregnancy rates dropped way, way down. So even though their sperm counts were good, like when you follow their sperm counts here, they're doing just as well as these other groups, their pregnancy rates went way down. Whereas if you did a low dose, it stayed stable pregnancy-wise, but your sperm counts did even a little bit better. And I just highlight this to show pregnancy rates. So these are all women 35 years old and younger, and you can see that the pregnancy rates here are roughly in that 2/3 range will get pregnant. So it's a little bit higher than those IVF ones, we saw earlier as far as a one-time procedure type thing. So vasoreversal patency, again, it ranges in the published literature, 72 to 99%. And again, that's published. So these are people who are generally relatively experts. They're in academic centers. They're relatively higher volume. So out in the community, I found this can be as low as even 30% or so. And then pregnancy rates range, and again, this is published, but it really could go all the way down to like 4%, all the way up to the 70% or so. So roughly, 2/3 the data that we were showing, here with it and here. And again, it's highly variable. So surgeon ability, you want your surgeon to be able to do epididymovasostomies. The majority of vasoreversals performed, surgeons performing these can't do epididymovasostomies, and that means that you may end up getting the wrong surgery done at the time of the case. Volume is really important. Technique is important. The post-op protocol, prednisone versus not. And it's important to pay attention to what data are they actually excluding when they're giving you a number for success rate. Because, some centers, for example, will say, we've got really high success rates, but they'll only operate on people less than 9 years out or highly select them. Or they'll only do vasovasostomies and only quote their vasovasostomy data, for example. So now, how much do you need to get pregnant post-op? There was a great study done back in 2017, which showed that basically if you're above 5 million, so if your concentration is above 5 million, whether you're 5, 15, 50, doesn't matter, you end up having the same predictive rate of developing a pregnancy. And it also shows that concentration alone is a great predictor. It doesn't matter if you look at total motile per ejaculate, motility itself, volume, whatever the case, concentration ends up being a good predictor. Now, the longer it's been since your vasectomy, now this is kind of older data. This was a compiled series of multiple surgeons over time. And this is true, but I found it's not as true or not as significant as is shown here when you have higher volume and more experience with it. But this is just showing that the more years that go by, the more likely you're going to need an epididymovasostomy on both sides. And again, that's why some surgeons will select and say, I'm only going to take people 9 years out and less because they're cherry picking the real easy ones. And same with IVF centers. Some IVF centers will only take women who are not obese and things like that. And so they're going to cherry pick for better outcomes in general. As time goes on, you tend to see lower overall patency rates and total concentrations. And again, that's because you're more likely to need these complex repairs. And if you do a complex repair, you're just going to have a lower success rate in general, even though it's better than not doing it. And then you see that fall with pregnancy rates as well. So again, if someone's saying, hey, I have real high pregnancy rates, you want to take a look and see, all right, how far out are the patients that you're operating on? If you're cherry picking easy ones, then of course you're going to have real high rates because it's just more likely that way. All right, surgical procedure. So pre-op, there's not a lot you have to do here. You just want to make sure that you can limit your activities afterwards. And ideally, you want to be able to have those limitations for about 2 months if you can. You want to be off testosterone for about 6 to 12 months in advance, and you want to be ready to achieve a pregnancy right away. Now, you may or may, there's some debate as to whether or not the female should undergo evaluation in advance of the procedure. In general, you wouldn't do it naturally, and so it's reasonable to say, all right, if you don't have any factors on the female side, then you can give it a try post-reversal for a while, and then if it's not successful, then you can go in and get evaluated. So, but there is some debate on that. The procedure itself, it ranges anywhere from 2.5 to 6 hours. Most of them for high-volume surgeons are in that 2.5, 3 hour range. Occasionally, you'll need real complex repairs, and it can get to be a little bit further. In our case, you can do it under pure local anesthesia. You can also do oral sedation or IV sedation. All those can be done in just an outpatient surgical center, real, straightforward. Or you can do general endotracheal intubation as well. All of those are options. There aren't a ton of centers that will do pure local for full reversals, meaning complex repairs and everything. So that one's a little bit harder to find. But in general, there's many options. In our case, if you do any of these top 2 options, you can eat during the surgery, you watch shows. There's a little holder for a smartphone for the patient to basically watch. So Post-op, the key thing is you need to be able to be a sick 80-year-old man for 2 months. So you need to take it easy if you want to have a good chance of success. And again, you want to try to get pregnant right away. Ideally, you want to save up the ejaculations for the first few months, meaning that you don't ejaculate at all except around the dates of ovulation. And then you try to have intercourse 3 to 4 times or so around that time. You also want to be really careful of sexual positions for the first 2 months. You don't want anything that's going to pull on the vas. And then plus or minus prednisone. Again, I showed a little bit of that data earlier, and I'll show you some here. So the reason I say plus or minus prednisone is when we looked at our study 1 year out, the pregnancy rates were similar between men who didn't do it versus men who did it. But the blue arm here is the low-dose prednisone, and you can see that it's possible that it's resulting in a longer-term higher numbers, meaning that maybe at 2 and 3 years, we might see higher success rates in the prednisone arm. We're still waiting for the data on that in our randomized trial. We also did an anonymous study, I haven't published this one yet, where we compared surgeons around the country to see, 1, how are outcomes, and 2, do they scar down over time? And interestingly, you can see there is quite the difference. Each one of these lines represents a different surgeon, and these are median sperm counts at the different time points. This is 2 to 4 months post-op, 4 to 7, 7 to 10, and so on. And you can see that there tends to be a trend over time that the repairs may scar down. But it's surgeon dependent. You have some who will get a little bit of scarring down, but not nearly to the same extent as some others. So there are some technique differences there. And these are all high volume surgeons, by the way. All right, if it fails, you can redo it. That's generally not the case if you do a complex type repair and epididymal vasostomy. Surprisingly, success rates are going to be similar to first-time cases. You can also do IVF, and it ends up becoming a numbers game where you just try enough things and eventually you'll find what works and what doesn't. So, but I think it's really important to set expectations that this isn't a one-time and you're done, guaranteed it's going to work type thing, no matter what you do, whether it's IVF or reversal. A lot of times you have to go into it saying, all right, this is going to be a process, and it may take a fair amount of trials to get through things. All right, complications are pretty low for reversal. Hematoma is about 5%, which is just a blood collection. Infection, probably a real number is about 2%. We call in antibiotics for about 5% or more, but a lot of times it's overkill, and we don't need it for most of those. Chronic pain, about 2% of men will still have some pain all the way out to a year. All of these numbers are going to be higher for redo cases, complex repairs, granulomas, things like that, and if you need epididymal vasostomies. We send people home with sperm kits. We used to use these at-home ones, and I just found they're completely unreliable. We also tried sending orders for them to get testing done locally, and it's highly variable. Some centers are great. Some centers don't have very accurate outcomes. So we send them home with these mail-in kits, and then when we get the sample, we analyze it manually. We can only tell concentration, but interestingly, we can tell fully formed versus sperm parts. And I'll show you that's important because, again, concentration is just as predictive as anything else, and so we can get the information there. But if you have a partial blockage, you'll get sperm only partially coming across, and they tend to lose their motility or become sperm parts. So if we see sperm parts on an analysis, that tells us that this repair is either opening up or closing down. So it gives us a real good early indicator what may be going on, inside the vas itself. Just a few, comments on selecting a reversal center. Advertising doesn't always match outcomes. So, and I didn't highlight it, but there's multiple centers, for example, that'll say on their website, they'll talk about epididymal vasostomies and these repairs, but then they don't actually do them. And so it's a little bit of a bait and switch in many cases. And higher cost, ironically, often means the person does lower volumes. And it's just because if you have to pay so much to get it done, not as many people are going to go to those centers. And so they tend to be lower volume in general, which is ironic because in most things in life, you pay more, you get more, and so on. But in the case of reversals, that's often the opposite. Very high variability in outcomes among surgeons. And I just highlighted one other one. So here, if you search my name, this one, isn't there anymore, but a competitor's website would pop up with my name in it. And so you click there thinking like, oh, I'm going to get Landon Trost, and it goes to a competitor site for it. So there's a lot of, weird stuff that goes on, and you can't always, believe what you see advertising wise. Just 3 final slides on male infertility in general. So number 1, male infertility is just as common as female infertility. Almost always people say this is a female problem, and it tends to come through their primary care, OBGYN, things like that, as far as or the referrals will come on that side because people tend to go on the female side first. But 15% of couples overall are affected by infertility, and male factor is contributory in about half of those. So number 1, male infertility is just as common as female. Number 2, If the man is infertile, and it depends on specific factors, but they have a much higher risk of other bad things in life. So testicular malignancy, for example, is anywhere from 2 to 20-fold higher rate compared to someone who doesn't have these infertility factors. If you have 2 or more semen abnormalities, your risk of mortality, meaning risk of dying earlier, is 2 to 2.3-fold higher. And then there's increased risks also for colon cancer, melanoma, prostate cancer, in addition to testicular cancer. So it is something, if someone is infertile and has abnormalities on the semen analysis, we need to, we want to know, because you're going to be higher risk of some other things as well. And finally, male age is likely important. You know, we always talk about female age being a key factor for infertility, but on the male side, more and more we're finding that the risk of certain conditions like, psychiatric conditions, bipolar disorder, psychosis, ADHD, substance abuse, schizophrenia, and so on is higher. Now, I do want to draw your attention to this, though, where the relative risk is 1.37 to 24.7. And that just shows we don't know what the real number is here. We say these are higher, but this is a huge range here, which says that the data is not super reliable. We don't know how much of an increased risk it is. It's probably, in the 2-fold range, higher risk of these things for someone who's older compared to younger. And with that, I thank you for your time and look forward to answering any questions you might have.
All right. Well, that was fascinating. Really a lot of great information. I do have one quick question. There was a point, at least on mine, where it cut out, and you were talking about where you were the reconnection, and there was some issues with strain on the sutures and something you were doing different. I couldn't catch what that was.
Oh, sorry about that. If it cut out for it. Yeah. So early on, we, developed a technique called revas, which is basically when you put the repair together, anytime you put any repair together, if it's, whether it's bowel, ureter, whatever the case, if it gets pulled on, it's going to make it more likely to fail. Either some of the stitches rip and then sperm comes out and it scars, or just the strain itself makes the blood supply less robust, whatever the case. And so we found a lot of failures happen because they either ripped apart or partially ripped apart and then scarred. But we started basically suturing together the base of it so that those would have to rip through first before it ever threatened your repair. And success rates went way up when we started doing that. The everything from sperm counts, the patency rates, pregnancy, all of that went up. We've since changed it to where we put this that same sheath from below on top, so that you get a lot more strength that way without creating this new big loop in there. But yeah, so technique-wise, you can optimize outcomes for sure, depending how you do it.
Good. That was the part I was missing, and I just trying to figure that out. It was kind of tough. Let's see. Just got to get this arranged here. Lori, you have any questions?
I don't think I have any questions, but I know that in our urology department, we had some physicians that did vas reversals, but they stopped doing them because you really do have to be kind of an expert at it and do it all the time to be good at it. So, and then the other comment I had was, we have a lot of, definitely a lot of younger patients getting vasectomies in the age of 20s. And, no matter how much you talk to them about it, it's something that you really have to have a long, lengthy discussion with those people to say, do you really want this at this age when they have no children? They've never been married. They haven't really gone to that level where they think about having children. So that's all I've got. Thank you. That was a great talk. Yeah.
No, yeah, it's very true. I remember when I started at Mayo, there was a real strict policy where nobody under 30, could have a vasectomy no matter what. It just was a complete non-option. We changed it when I got there, where I said, well, we'll consider it under 30. So we'll look at the factors. You have 11 kids under 30, fine. But I agree with you. I mean, it's one of those things where people will say, oh, you can reverse it. Well, you can, but it's going to be time and money, and it may not work fully. And I mean, it works for a percentage, but it's not 100%. And you hate to, everybody thinks they're done with kids at one time, but a lot of times what happens is they either lose their partner, or they have either from death or divorce or something along those lines. And then suddenly a new partner comes in, and now they, that becomes a real sticking point in the relationship. So it's very true.
And then we have the other extreme where we actually had a patient who's in his 70s that wanted a reversal.
84. So I think we have
Wow.
the longest ever. So we have someone he was 48 years out from his reversal. And so to my knowledge, that's the longest one, ever. But, surprisingly, they're just as successful. Like at a certain point, that decline that I showed in the slides levels off, and it doesn't matter if you're 10, 20, 30, 40, whatever years out. But yeah, and it was 84, and I thought, are you in here for this, or are we doing something different, or what's going on?
Wow.
That's crazy.
I was kind of taught that the reason they didn't work, if somebody had like over like 10 years,
Anasperm antibodies?
It was sperm antibodies. I was going to ask you about that.
Mm-hmm.
Yeah, that was not true, but it was real popular, like you said. So about early 2000s, it was and it's all over, Facebook groups and things like that still, because it just keeps circulating over and over and over again. But yeah, early on, the thought was, after it's been so many years, because people were trying to make sense of that. Like, why is that the case? If it's been so many years, why is it more likely that it won't work? And they said, oh, it must be antibodies. Over time, your body attacks, because sperm is haploid. And so it's not, your body's going to recognize it as foreign. But what they found is post-vasectomy, everybody gets anasperm antibodies, and then the titer comes down with time. And so usually if you have a persistently high anasperm antibody titer, it's in a case like a granuloma or something where sperm's constantly leaking out. But it has no relevance at all. In fact, anasperm antibodies even somewhat predicts success, because it predicts that you have a granuloma if you have persistently high titers and things. So it now isn't, it's still on the internet and things like that. It floats around forever, but it doesn't have any relevance for outcomes.
And we always talk about dogma around here, what we've always said, and it's kind of interesting to challenge it. So yeah, that's great. Are vasectomy reversals covered by insurance at all?
Not really. Occasionally people will have like a plan with their employer where they'll have like a certain benefit for fertility services, especially like tech, it seems like, is getting more and more of these fringe benefits where, you can have up to $25,000 for fertility, but rarely is it covered by insurance. And as you know, the tricky thing with insurance is you usually can't do both. So you can't allow insurance and not allow insurance. You can't do this like 50-50 type game. And so you either have to offer them all for insurance or none for insurance. And then the problem with insurance is they'll usually only pay you like 15% of what you ask. And so you have to charge like $20,000 for these reversals now, knowing that insurance may, pay $1,500 or $2,000 or something. And so that means everyone who comes in, even if they don't have insurance or don't have coverage, they have to now pay the $20,000. And so most centers have adopted a cash-only policy for these, just because of those issues. So
still probably compared to in vitro is less expensive, right?
Yeah, most run in the $5,000 to $12,000 range. So when you look around the country, it's typically in that range. We're just really low because, again, we don't take a profit on them. So we do it as a break-even point. And so ours is like $3,000. But the next lowest, to my knowledge, that does complex repairs is in the $7,000 to $8,000 range. And then there are a couple others that do them in that $2,000 range, but they don't do the full reversals. They just do vasovasostomies only.
How often do you guys do semen analysis afterwards if they don't get pregnant?
I found if you don't give them a real easy way to do it, almost the majority won't ever get one, or they'll maybe get one. And it's real misleading because you may get one and say, great, it's successful, but these change over time. And so we typically get one at 2 weeks, 3 months, 6 months, and a year just to see the trend. And if it were me, I would even go 2 years, 3 years, forever. But eventually people, move on with life and don't keep checking things. But it's helpful because you get to see that, okay, this is going up and down, or this didn't open up yet, or it's closing down. Because otherwise couples are wondering why we're not getting pregnant. And it's good to follow the trend over time with it.
At what
I
point
assisted
do
a group
you
of oh, I'm sorry, go ahead, Lori.
No, that's okay. At what point do you do a repeat it?
A redo type thing?
Yeah.
Yeah, a lot of it, if their number's above 5 million and it's consistently above 5 million, then we usually have them get a formal one to make sure that, that motility is intact, everything on that side is good. If it is, then we look at the female side and say, all right, are there any female factors that may be contributing? It's tricky because I think all of us feel like, all right, 500 million must be better than 5 million. But when you look at the data consistently, it's not. And if you're above that threshold, you're just as good. And it's tricky because post reversal, they're never as good as they were pre-vasectomy. And so, someone may have 20 million and say, well, that's why I'm not getting pregnant. But it's not. There's like other factors, and a lot of times we'll have like a 39-year-old, 40-year-old partner, and at age 40, 85% of oocytes that are ovulated have 2 or more chromosomal abnormalities, meaning only about 1 out of 10 months has any chance of pregnancy, even in the perfect setting. And so I think a lot of couples don't realize that, because our goal is to keep the sperm counts in that consistent range so that when a good egg does come down, it gives a good chance to fertilize and to get pregnant. Now, if you're 25, it's a different story, but age definitely plays a factor.
So my question is, so I've worked with 5 different urologists and assisted in vasectomies with all of them. And someone would just take out a little section, and one guy just snipped it and turned it on its side and stitched it over. Then I had one urologist, he would take out as long as he could. Now comes the repairing that are going into a reversal. Does it make a difference? Is there some point you just can't do it?
No, nobody ever asks us, but we would definitely give them a wish list if they came and said, all right, what kind of vasectomy should we do? And I mean, in general, if they go really high, really low, that is difficult. It's going to, make things tougher. Taking really big segments, we have to bypass that whole segment. And so it burns bridges for future ones. There's some data that says if you go at a certain level, it's more likely to require a complex repair later. If I had my preference from a vasectomy standpoint, that'll give you the best outcomes on the vasectomy, plus will make it very repairable in the future, would be to leave the bottom end open. So don't clamp it, tie it, anything like that. The top end you burn, and then you do fascial interposition, where you put a layer between the two. Fascial interposition is the one thing that's been shown to be important as far as success rates for vasectomy. And then from our side, that means you don't have to take a big segment. You can leave the bottom end open, more likely to form a granuloma, more likely to be successful later. That would be my wish list. But again, usually when you're going to blow up a bridge, you don't care how it gets blown up. The key is, make them infertile. So.
Now, when you say the bottom end, you mean coming from the testicle?
Testicle, yeah.
You don't feel that, so it's just leaking sperm into the...
Yep, and those ones do better because, and no one knows exactly why, but it kind of makes sense. If you block a pump and it backs up all the pressure in the pump, you're going to be more likely to have it fail over time. And that's, in my opinion, that's why you see that downtrend over time of how many years it's been, just because when it's constantly think of any organ that's constantly under pressure, it just fails faster. And so if you leave that bottom end open, so it has a pop-off valve, everything's able to drain. I mean, think about a kidney. You obstruct a kidney, it's going to fail. You leave it open. Even if you bring it out through the skin, you keep a stent in, whatever. As long as it keeps draining, it'll stick around forever. So that would be my preference. But again, we fully recognize. Patients always say that they say, "Oh, did my surgeon butcher me?" And we never say. We say their goal was to make you infertile, and they succeeded. So that was their task.
Yeah, the long segment guy said, "I've never had a failure."
Might be true.
Probably. He was proud of that. That patient wasn't as happy. These were all done under local. It was a little pulling. Is there anything about, as far as like when you do this connection to the epididymis, like I thought there's a certain amount of sperm immaturity coming from the testicle versus... Good
question. That was another one where originally they thought, hey, this is a bad idea because don't you need the epididymis to mature? And isn't that one of the key steps in development? Later on, it was kind of the era of ICSI, when we're taking sperm directly from the testicle and putting it in the egg, and they do just as well. So sperm are fully mature, fully able to fertilize as they're in the testicle itself. So that was kind of a new learning that wasn't known, previously. And so there is some debate still, depending where you connect on the epididymis, as to how your pregnancy rates are. If you connect high, there's some people that say, oh, those won't lead to as much pregnancy as compared to low. In reality, though, you don't really have a choice a lot of times. When you're doing this, you shoot for the tail. And this depends. There is surgeon variability here. But you shoot for the tail. And if you can find a spot on the tail that works, great, use that. But if not, you have to slowly march up until you get potentially all the way to the head. And so a lot of times you don't have a choice. The reason we really love attaching to the tail is because you can flip that up. You can do something called epididymal disarticulation, where it's almost like an epididymostomy, where you lift it up and now it gives you like 2 extra inches of length, and it makes it much, much less likely that the person's going to have like a high riding testicle, especially if the surgeon did, like you said, real big segment, or they took a real high one. It gives us a lot more flexibility in being able to repair that.
So a lot of myths you're dispelling here today.
Oh, there's a ton in fertility. Yeah, it's 1960s medicine in a lot of ways compared to other areas of medicine. So
yeah, oh, that's really great. Audience, if there's any questions out there, feel free to put those in. Any comments, go ahead. Otherwise, Lori, if you have any other comments or questions you might have.
No, you answered all the questions I've had in the past 6 years since I don't see the vas reversal. So I appreciate that. Thank you.
No, yeah, it's my pleasure. And like you said, it's a niche area. And like you said, if you're only doing like 2 or 3 a year, on the surgeon side, you feel guilty. You feel like, oh, I may not be, giving you the best outcomes on it. And so I think a lot of surgeons do quit doing them just because, they don't want to. You always want to do what's best for people, and you hate to do something where you feel like, oh, I may not be able to offer you anything and everything. It's a tiny, tiny little niche.
Mm-hmm.
I'm guessing your referral base is pretty big from outside of Utah.
Yeah, surprisingly. Yeah, 92% come from other states or countries. Almost all of them are from other areas, just because there's just not enough volume in any one state. If you're going to be real high volume. So.
Oh, we do have a question. So Susie would like to know, how long does the reversal procedure take, and is it done under the local?
So on average, it's 2.5 hours. And it's a big surprise because people get a vasectomy, it's like 10 minutes. And I just had one yesterday who said, oh, I told my wife it was going to be 30 minutes. I said, well, I hope not, because that's a red flag. So typically 2.5 hours, and it kind of is volume dependent. If you don't do as many, then it can be 4 to 6 hours pretty regularly. If you do more, then it tends to be 2.5 to 4 hours. Local, so it depends. That's one you want to ask the surgeon specifically. To my knowledge, we were the first to publish doing complex repairs, so the epididymal vasostomy is under pure local. And so I think since we were the first to publish, it must not be super highly commonly done. Most people do these like in a surgical center with anesthesia and things like that. But there are some who can do the full thing under pure local. Otherwise, you can do oral sedation, which is just like oral Versed. Makes half the people fall asleep. It relaxes you. You can do IV Versed, which is moderate sedation. We bring in an anesthesiologist for that, just for safety purposes. Or again, you can do deep sedation, full general endotracheal. We pretty much never do that. I don't really see a reason to do that, but that's commonly done too.
Yeah, I bet it would be hard for a patient, though, to sit there if it's under a local for 3 hours.
Yeah.
Sit in the same position, it'd be hard.
We usually say if they're, morbidly obese, bad back, that type of thing, then you're probably going to be happier being sedated somewhat. But if you do local plus oral sedation, they usually fall asleep, and they'll move on you. Like just like they're sleeping at night, they'll twist a little bit and things, and it's fine. Like you just get used to it. So.
Well, that's great. I'm guessing that with the number of young folks out there that are going in for vasectomies without having ever had a child is going to push the vas reversal rates up a bit in the future.
No, I think so. Or you never know. I mean, I think technology in the next 10, 15 years is going to grow quite a bit on the IVF side. And so I think if you could get prices down, drug costs down, and success rates up a little bit, I think IVF would likely overtake things. Guys don't like being operated on, and so a lot of times on the fertility side, it's very, a lot of times it's the women who are driving a big portion of it, and they're having to convince the guys to do it, and so I think if they can optimize things a little bit more on the IVF side, I have a feeling that numbers of reversals will decline over the next 10 to 20 years.
Yeah, definitely. Good point. Well, thanks. This has been fascinating. I really appreciate having you on the show. I'm going to put a quick plug in for next week's show. Please join us for this.
Dr. Aaron Berger discusses the role of treatment for patients with metastatic and non-metastatic castration-sensitive prostate cancer with biochemical recurrence at high risk for METs. He emphasizes that Xtandi, an androgen receptor inhibitor, offers a significant therapeutic advantage by impeding the androgen receptor signaling pathway, which is essential for the growth of prostate cancer cells. For patients with metastatic castration-sensitive prostate cancer, incorporating enzalutamide into their treatment regimen can markedly slow disease progression, reduce the risk of new metastasis, and improve overall survival rates. This strategic intervention allows for better disease control and enhances the quality of life for patients undergoing treatment. Join us next Saturday to learn more on uronurse.com.
So yeah, join us next Saturday for that. And for those of you that are patients, be sure to check out our UroPatient podcast, which is at uropatient.com. Follows this show every Saturday at 10:30 a.m. We're always talking about something interesting. Today, we're going to be talking about some treatments for erection problems. So once again, Dr. Trost, great having you on the show. I'm glad you were able to join us. Lori, always a pleasure.
Thank you.
And everybody have a great weekend, and we'll see everybody next week. All right.